We can get underway. Thank you all for joining us for year 3 of our clinical faculty development series. We're very excited today to have Dr. David Beyda from the University of Arizona and College of Medicine in Phoenix to do this presentation. And with that, I'm going to turn it over to you and let you go.
Thank you so much. I really appreciate the opportunity. When I was asked to put this together relating to the ethical physician, I wasn't sure what that really meant. Was that, are we looking at a physician who needs to kind of toe the line, so to speak, and move in that direction, or kind of are they practicing outside the boundaries? And so as I thought about this, as you'll see, I kind of took a different slant. But let me give you a little bit of background first. I'm a retired pediatric intensivist, about 45 years at Phoenix Children's. I chaired the hospital ethics committee for that many years. And my medical ethics training and study all was done at Georgetown. I studied under Ed Pellegrino as a visiting scholar at the Center for Clinical Ethics. And I studied under Beecham and Veach as a visiting fellow at the Joseph and Rose Kennedy Institute of Ethics. And so I come from a background of medical ethics centered on humanism. As you'll see, that's kind of where I'm going, and spent a lot of time with them. And then when I retired, I was invited to be the chair and professor of the Department of Bioethics and Medical Humanism here at our College of Medicine, Phoenix, at the University of Arizona, where I've been here for several years. And as such, developed the curriculum and the focus on what an ethical physician is. So let me move forward. And first of all, I'd like to just give kudos to the authors of Chapter 15, Developing Ethical Physicians. What a wonderful piece of work that they did, putting together the needs for developing ethical physicians. I didn't think that I needed to spend any time at all in adding to what they already had, which is the reason why I took a different perspective and a slant on what an ethical physician is and who they are. But I wanted just to give them some kudos for just a very nicely written chapter on developing ethical physicians. So with that in mind, let me tell you how I'm going to take a different approach. I'm going to really focus on the bedside care of what we would envision ourselves as ethical physicians, looking at clinical care and how that relates to our moral responsibilities as a physician. I'm also going to reinforce the notion, because of this whole concept of humanism, that medicine isn't just a science, but it's infused with moral responsibilities that we have as physicians relating to who we are in our relationship with patients. So there are 2 books that I look to often when I look at ethics at the bedside. The Way of Medicine, which came out about 2 years ago by Kurlan and Tollefson, The Way of Medicine, Ethics in the Healing Profession. And then, of course, no shame in this, studying under Edmund Pellegrino, his book For the Patient's Good, The Restoration of Beneficence in Healthcare. I take a lot from both of these and hope to share some of that with you as we move forward, looking at what this whole holistic approach of being an ethical physician is as it relates to our relationships with patients. So my to-do list is to go through these 4 areas. I'm going to emphasize of treating the patient as a whole. I want to look at the patient as a who, and not necessarily at their disease, as you'll see in a little bit, and how we encompass and embrace the emotional, social, and spiritual needs. I'm going to talk about the inherent power differential between us and patients, and why that's important, and how we have to decide what type of relationship we want to have with our patients in order to be truly an ethical physician. I'm going to talk about honest and compassionate communication. And I want to really emphasize the value of the human touch and personal connection in patient care, which is all about the caring aspect of who we are when we're with patients. So why ethics? Why is it important for us as physicians to really engage in ethics? I mean, we all believe we already have a strong moral foundation, So why do we need ethics? We can deal with these ethical issues easily. Well, not so fast. I think there's such a lot there's such a lot of underlying aspects to each one of these, and these are just a few of the ethical issues that we face as ethicists when we're called to do a consult, or when physicians are at the bedside trying to understand, for example, what does veracity really mean? Truth telling. What does it really mean? What does it really mean when you're actually withdrawing support from a patient? Are you assisting them in their death? Are you allowing them to have a natural death? Question is, how can you have a natural death in an ICU if you're withdrawing support? These issues of do not resuscitate. What does that really mean? What is informed consent? To be fairly open about this, I don't believe informed consent exists. I think that we as physicians, and this is where the ethical physician comes into play, that we have to be really conscious of this, that we give just enough information to get the answer we want from the patient. Well, that's not informed consent, that's coercion. And so there's different ways that we have to look at this when we embrace the concept of physician-patient relationship. Can we tell the truth when we're giving informed consent? Giving the patient the opportunity to either deny or agree to whatever we're asking of them in a procedure or a therapeutic modality. So here's how we have our ethics curriculum at our College of Medicine, and it's important for me to kind of share that with you, because this is the foundation of what we do in guiding and coaching our medical students to be ethical physicians. All our lectures are active learning, and they're all mandatory. We have a sense of where students do not have to attend lectures. Everything's recorded panopto, so they can look at it at their own speed. But all of our ethics, the whole ethics curriculum is mandatory. We have learning studios where I'll put 6 to 8 students in a group, and they serve as ethics committees. They're given a case and they have to attack it. The topics that we talk about are related to the block that the students are in. We have blocks where we talk about, the gastrointestinal block and the cardiovascular block, et cetera. And I use Poll Everywhere to engage students, forcing them and really encouraging them to express their current moral and ethical beliefs related to the cases posed. And it's fascinating to watch. In our classes are 120 students, to watch in a class of 120 to see how disconnected sometimes they are among themselves in terms of how they answer the Poll Everywhere questions. There have been times when there has been contention within the class, with students finally realizing that their best friend is not on the same page as they are when it comes to answering the Poll Everywhere question relating to a moral and ethical belief related to the case. Our theme is all about the who, the patient, and not always about the what, which is the disease. And I'll talk about that as well. And we really stress in our curriculum about embracing the being present when present with patients. And of course, we bring the principles and moral theories forth as we move through that. So the principles of bioethics are no different than, are taught no differently than any place else. And we go through these and we use these as a foundation for the assessment of the cases that are presented. And here's how we go about doing it. Our department, I was fortunate enough to have embraced and be a chair of a department that is inclusive of bioethics and medical humanism. And so we have a very robust humanities program that's embraced within our bioethics department. So we have not only ethics, but we have a very robust narrative medicine program. We have an arts and medicine program. We have humanities electives, history of medicine, research ethics, global health ethics, art experiences. And as you see, we actually have a health humanities certificate of distinction. So we really bring the humanities aspect to medical ethics at the bedside for our students. 2 years ago, we actually got approved. We have a master's degree in bioethics coming out of our department. We also have a certificate in bioethics coming out of our department. And so we have a dual degree program for our medical students who can engage in graduating with a medical degree and a master's degree in bioethics. And if they enter into the Health Humanities Certificate of Distinction, they graduate with that as well. So it was important for me to really engage in sharing that with you, because of the ethical physician really encompasses a lot of the humanities aspects that we do. So how do we do this? Well, in the first year, our students have about 22 lectures. They're all interactive, case-based. So we're talking a significant amount of time. The second year as well. Third year, I meet with them during their clerkships, and then the fourth year, the same. So we get engaged with a lot of different encounters relating to the learning of the medical ethics in our curriculum. So we start off in year one with basic ethical concepts and moral theories, kind of using cases to bring them back. We then apply those to the concepts and moral theories to critical issues in year two, and then year three and year four, the students are now interacting with patients, and that's when we begin to really incorporate what they've learned at the bedside, learned in the first 2 years at the bedside, and how does that come across? So the theme centers around, look, the patient is not the dilemma when we're faced with an issue of ethics at the bedside. We don't want to isolate the patient, and many times the dilemma centers around interpretation, values, judgment, misunderstanding. So we really make sure that our students understand that they have to have a way to begin to interpret the dilemma, that they have to understand the values coming from both sides, understand that judgment can be biased, and to really realize that sometimes misunderstandings can come out of these ethical dilemmas. So one of the things that a response is not necessarily expressive, that they can't state an opinion without moral justification. They have to be careful about being pre-reflective, where they have an inappropriate or incomplete attempt to justify judgment, and that we really want them to be reflective. And this really applies to the ethical physician at the bedside. Always be reflective. Be consciously adopted, rationally, morally defensible, and open to critical moral scrutiny. Be able to look at yourself in the mirror and say, I think I did what I should have done. I did what was best for my patient. So what ethics is not, they're not mere opinions or intuitions. Our students are entitled to an opinion, but we ask them to kind of look a little further than that. We don't necessarily want them to look at just the law. Sometimes ethics and the law are like oil and water. They don't mix. And that what the law is telling you to do may not be the best thing for your patient. And you have to look at the ethics of that as well. Religion may inform ethics, but ethics is a secular enterprise. And we know that science may inform ethics, but moral decisions are normative decisions that we need to be engaged in. So with that in mind, let's kind of go through where we're headed with this whole concept of the ethical physician. In today's medical medicine, you see the imbalance with medical humanism. Medical medicine looks at the what, just the disease, looks at the business of cure, looks at science, and looks at technology, where the medical humanism, where the ethical physician, when they are at the bedside, they really need to spend time looking at the who, looking at and with the patient, with empathy and communication. And that's sometimes hard to do. It's a hard taskmaster, because you have to enter into this relationship, which I'll talk about in a moment, where the patient is willing and the physician is willing to engage in a shared relationship based on shared values and common values. Because if not, there's going to be some contention. There's going to be a disconnect between the two. So let me give you an example of how our students grow over a period of 4 years. In their very first year, one of their very first encounters with me, I showed them a picture exactly like this one of anencephaly, and explained to them that anencephaly engages with this physiologic aspect of no consciousness, memories, emotions, and positive and purposeless actions. So I pose a proliferative question. do you believe someone who is anencephalic, and I try not to use the someone because that kind of is a leading question, is an anencephalic a person or not? Thinking about what this is all about. And I did some significant studies. I took 3 consecutive years of medical students. And if you see within the first year students, 62% of them said they were not a person. So I showed the picture in their first year, and then I did it again in their 4th year to see if they changed. And these are 3 consecutive classes of 120. So there's a significant number of students there. Notice that across the board, all 3 classes, pretty much consistent. In the first year, not a person. But by the time they got to their 4th year, they realized that a person is a person no matter what. And the reason we did this was because of the humanistic side of how are you going to approach a patient who's vegetative? Are they no longer a person to you as an ethical physician? How do you engage with them? Do you feel comfortable speaking with a vegetative patient or someone who has senile dementia or Alzheimer's? So when I combined them all, we found that there was a statistically significant change in their concept of personhood related to the humanism side of being an ethical physician. And so a lot of the pull everywhere questions that we pose to our students centers around this whole concept of what does it mean to be an ethical physician at the bedside. So how do you define an ethical physician? And this is kind of how I look at it, and this is how I ask our students to think about it. And we've had focus groups, first year, second year, third year, and 4th year students to kind of answer this question. The ethical physician, from their perspective and mine, is committed to the well-being and dignity of their patients, that they have thoughtful decision-making, that there's trust and respect for both patients and peers. So this is kind of where they're at. And I'm not sure what your medical school does, but our first year medical students, our students write their own Hippocratic oath. So they, each class has a different oath that they come up with, that they write, that's based on their moral and ethical response to who they believe they will become as physicians. Interestingly enough, Kirkpatrick in 2006 really kind of identified medicine as an art and science, wrote, eventually there comes a time when science cannot stave off death or suffering, and the strict practitioner of medical science has nothing more to offer. And here was the key, but the practitioner of the art of healing always has something to offer in the form of what? Attention, compassion, empathy, and even wisdom. There's the humanistic side of what we're talking about. And it goes even further when we look at the ethical physician as being medically humanistic. And so here's 5 questions I ask that we as ethical physicians of ourselves when we are at the patient's bedside or when we're engaged in dealing with ethical dilemmas. Is the technology that we're using a necessity for the patient, or is it a convenience for us? And I'll get into that here in a little bit, and we'll kind of explore that. Are we treating the patient, the who, or are we focused on the disease, the what? Do we have a contract or a covenant relationship with our patient? What is the difference between the two? And I'll kind of go over those. And do we take care of or care about and care for our patients? Those are 3 very distinct parameters of caring that we'll talk about. And the last thing I want to ask of ourselves is, are we doing something to or for our patients? Each one has a unique perspective. So let me get into this issue of caring, and it centers around the reality of being unheard. Beautiful quote, do my doctors know who I am, who I've been, who I still want to be? Do they understand what I'm going through, my suffering, my pain, and my distress? Do they understand my hopes and aspirations, my fears, shames, vulnerability, and strengths, my needs and obligations and values? Above all, do they sense my personhood and my individuality? Do they acknowledge my humanity? And key point, do they care? I think that's powerful in terms of what we as ethical physicians need to keep in mind, that when we are at the patient's bedside, how much do we care for the patient and care about? The reason is because we all believe that caring is a common virtue. It can't be taught. Either, we have it, or sometimes we don't. Science, technology really has been pushing us sometimes away from the whole concept of caring. Some say, have our culture has forced us to move away from the art of healing to become the business of cure. We've heard that. We've seen that over time. Look at the number of patients that physicians have to see to keep up with their contracts with healthcare contracts. 50, 60 patients a day, moving them out over 15, 10 minutes of time. That's not necessarily caring. That puts the physician in a difficult position of trying to be an ethical physician, of understanding who the person is sitting before them versus just dealing directly with the disease. So, do we take care of, or care about, and care for our patients? Taking care of someone, I believe, is procedural in nature. It's a procedure. I can take care of you. I will do this, 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 and this. But how far are we willing to go as a medically humanistic physician, an ethical physician? How far am I willing to go to care about you and to care for you as my patient? It takes some courage, and sometimes you have to be bold about it. You have to be willing emotionally to go that way. I will make an observation after practicing critical care for 45 years and share with you that I believe nurses care better than we as physicians overall. They find a way to move from not only taking care of their patients, which they do incredibly well, to care about them and care for them. And I learned a lot from the nurses that I worked with in the PICU about what it meant to care about a patient and to care for a patient. There were many lessons that I learned even from parents who shared with me that after slapping my hand, that I didn't care enough about their child, that I was more focused on the what. And I'll share with you a real story. This was during my younger days as an intensivist. I was did neuro-intensive care, really focused on cerebral metabolism and blood flow. And I had a little patient, Jeffrey, 4 years old, who came in with multiple injuries from a car accident, significant head trauma, abdominal trauma, et cetera, et cetera. And I'm making rounds with about 15 people on rounds, and I'm pontificating with poster paper on the wall and writing about physiology and this and that. Our parents always attended rounds with us. And mid-sentence, the mother says to me, "Excuse me, you don't really know who Jeffrey is, do you? You just know what he is, a bunch of broken pieces that you're trying to put back together again." That for me was the beginning of my understanding what it meant to be really engaged in caring about and caring for a patient. And I started writing about that, and that's when I got invited to be a visiting scholar and a fellow at Georgetown. And our whole philosophy in our ICU changed. It went from, yes, we will take care of the patients, but we'll move forward in caring about and caring for them as well, in order to maintain that medical humanistic aspect of being present when present with our patients at all times. So the ethical physician needs to be able to feel comfortable moving from taking care of to caring about and caring for. And so with that in mind, let's go to another question. Do we treat the patient or do we treat the disease? How do you balance those, and what does that really mean, and how do we go about answering that question at the bedside? Well, here's what we need to understand. Some of the patient's experiences of medicine center around these 6 things: interminable waiting, rushed office visits with impersonal doctors, worries about problems with insurance, power and knowledge asymmetries, conflicting evidence, conflicting advice, baffling direct-to-consumer advertising. That's what a patient feels and sees. But here's how I'd like to bring this out as well. I'm going to present the physician's perspective of medicine and then the patient's perspective. So the physician The physician feels that the illness is a disease process that can be measured and understood through laboratory tests and clinical observations. The patient says, no, illness is a disrupted life. And I need you to understand that. We focus more on keeping up with the rapid advances in medical science, doing our best to understand the patient's feelings and concerns, but not necessarily doing a good enough job about it. Patient satisfaction comes primarily from a sense of being heard and understood. And then we do not see the role of physician as listener. I'm not being generic here in terms and being fairly broad viewed, but instead we see our function more as a fixer. And patients feel devalued when their illness is reduced to mechanical process. Doctors feel frustrated, even betrayed when patients withhold important information. And patients who use alternative medicine aren't going to share that with us because they don't necessarily trust us. So there's different ways that we need to kind of look at that when we talk about are we treating the patient or are we treating the disease? So it's all how we begin the encounter. So one of the things that we teach our medical students, not only in doctoring, but in our ethics classes and pretty much in everything else, is here's to embrace the encounter. You know, we can do it two ways. You meet a patient for the first time and you can get right into the chief complaint. Hello, Mr. Smith, I see that you're here because you have a complaint that you've had abdominal pain for the last 2 weeks. You can go right into that. Or you can start off with this. Mr. Smith, thank you for coming. I know that you have some concerns about your pain in your abdomen, but this is the first time you and I are meeting. So before we get into your concerns about your abdominal pain, tell me a little bit about yourself. Tell me a little bit about what you do. Tell me a little bit about your life. Tell me a little bit about what's going on. That's the beginning of having the encounter with a patient rather than moving directly into the chief complaint, which is the disease. That's how we begin to have that medical humanistic approach to medicine and with our patients. And so I think it's important for us to kind of look at that. What about this question? Are patients better off because of what we do to them or because of what we do for them? What we do to them is procedural in context. I can do anything to my patient. I can put a chest tube in, I can do this, I can do that. But unless it's going to be something that is going to be centered on a patient's benefit, that means, is it going to be for them? I really shouldn't be thinking about doing anything to them. This kind of comes up and came up in the PICU for me when I was being asked by parents of children who were moving towards the unfortunate aspect of terminal illness or injury, of saying, isn't there anything you can do more? Can you do this? Can you do that? And I'd say, well, let's talk about I can do something to your loved one. Well, let's not talk about whether it's going to make a difference. Is it going to be really for your loved one, for your child? Is it going to make a difference? Is it going to really be of benefit? And once we had that conversation, it was very eye-opening for the family and for the medical staff and for the team that was there to care about and care for that patient. That, yeah, we can have the expertise to take care of everyone, but we need to do so when the context is for them, centered on a patient's benefit, not just because we can do something. So with that in mind, what about this question? Is the technology we use a convenience or a necessity? Well, you know, the technology out there is out there. And we can, as I mentioned here, we can easily get ahead of ourselves and focus too much on the science and not enough on the humanistic and moralistic side of things. Hence the technological imperative. Why the discussion? If there is something that is technologically available, it seems that we need to use it. This technology becomes the focus of attention rather than the patient. And there's circumstances where we backed ourselves into the wall because we started a technology without asking the key ethical questions of what's going to happen if we can't get them off this technology. Let's go way back to when ventilators were first introduced. No one thought about, well, yeah, the ventilators are great. We can ventilate a patient and they'll do better and they'll come off. What are you going to do if they can't come off? What are you going to do? How are you going to have that conversation with a patient or even a family when they can't come off? I'll share with you another story. When ECMO was first introduced into our pediatric ICU, we struggled with the ethical issues of whether we should even start ECMO on a patient, or whether we could even begin to have a conversation relating to how are we going to stop it if the patient can't come off of it. So as you know, with ECMO, you don't necessarily have to be heavily sedated and muscle relaxed. Our pediatric patients would be on ECMO sitting up watching Disney Channel and Nickelodeon. And every day we would come in and turn the flow rates down, trying to get them off of ECMO. And it could have been a cardiac ECMO, or it could have been a respiratory related ECMO. But there were times when we were unable to decrease the flow. They were not going to come off ECMO and live, period. How do you have that conversation? How do you have that conversation with the family? And how do you have that conversation with the child? It all centers around this whole technological imperative of making the right and best decisions at the bedside before you engage in the use of a technology. The ethical physician will think long and hard about using a technology that may cause significant issues related to how are we going to get this patient off. There were times when we were faced with very difficult decisions and conversations that we had to have with families and with young patients. I can tell you though, those were very traumatic. If you want a definition of moral distress, that's moral distress. And then, as you know, moral distress leads to what? Moral injury and leads to moral residue. And there were many times when we moved through those three phases of moral distress, ending up with moral residue, where we were really having to face ourselves in the mirror and looking at, did we do what was best for this patient because of the technological imperative? So let me show you real life. This is how we've progressed. We've progressed from listening to taking a picture. Years ago, how did physicians listen to the chest and the heart? They put their ear on the patient's chest. How many of us would be willing to do that today? And then they had the old stethoscope, which was a tube. Now we have the stethoscope. But lo and behold, do we trust ourselves enough when we hear a murmur to kind of make a diagnosis? Not necessarily. We get an ultrasound or we get an echocardiogram. So that's where the technology comes into play. That's how we work on moving that technology. So here's what I'd like to share with you. This picture here is one of my patients years ago when we first started using ECMO. Absolutely a necessity to keep this patient alive, but also to ensure that this patient would have a life when they came off ECMO. But where's the child? Way back here, way back here. So you had to really kind of stand up on a stool. You had to really look for the patient. Take a look at this patient who's being readied for transport on ECMO. Where's the patient? How would you engage in a medical humanistic approach of being present when present with these two patients? And then I'll share with you another story. It's one of my patients from years ago, complex issues, cardiac, respiratory, on technology. And it came time for us to have an honest discussion with the family that this young child had to come off life support. And the parent said, you are the one who's going to have to make a decision, because he can't die even if he wanted to on the technology that you're giving him, that you have him on. And they were absolutely correct. Long and short of it, to be really honest, in an intensive care unit on technology, If it comes time to where we make a decision that the patient needs to be withdrawn because there's nothing more we can do for the patient, that's futility, the patient dies by appointment. What do I mean by that? Well, I'm making rounds at 7 o'clock in the morning. It's going to take me 3 hours. We'll be done at rounds at 10. We've already discussed with the family that we're going to withdraw support. At about 10:30, I'll come back and we'll withdraw support. So at 10:30, that's the appointment for when we withdraw support. I think it's important for us to understand that when you use technology, there's two questions you need to ask yourself. Not only is it a necessity, but a convenience, but technology may just keep a patient alive and not necessarily ensure that that patient will have a life if they can even come off. So the ethical physician continues to kind of embrace these questions, looking at where are we going to go and how are we going to incorporate all of this as we move forward. We did a study in our ICU. We had a 48-bed PICU. And one day after rounds, I really wanted our residents and fellows and our medical students to understand the whole concept of the technological imperative. So we went around to every single room and we listed every piece of technology that was attached to and or near the patient in every single room. Then we went back to a conference room and we started going through each one, asking the question, is this piece of technology a necessity for this patient or is it a convenience for us? And the results were more than 53% of the technology we found in those patients' rooms were a convenience for us and not for the patient. And so we started asking the question, why burden the patient with the technology when you can look at the patient and make an assessment of what's being done, what needs to be done. So go from there. So moving forward, here's the next question. We have to decide who we are and what our relationship with our patient is going to be. Is it going to be a contract or a covenant? What are the difference between the two? Well, it centers around this whole concept of physician autonomy and patient autonomy. And as we know, patient autonomy really holds all the cards in medical ethics today. There's times when the physician autonomy needs to be held at a higher level than what we have it now. We need to be able to have our own autonomy in making decisions at the bedside, as well as the patient making decisions with them, not necessarily for them, but with them. So why the discussion? Well, because we see that this vocation that we're in is changing. We say that honesty is the best policy, and I shared with you that informed consent, not necessarily true. We'll give just enough information to get the answer we want. Being facetious, but I'm declaring a point. And we talk about the importance of respect for others, but how do we treat those around us? How do we treat patients if we just take care of them and don't move to caring about them and care for them? So this is not new. Let's go back to Seneca. Fascinating. He wrote, if therefore a physician does nothing more than feel my pulse, instructing me what to do and what to avoid without any feeling, I owe him nothing more than his fee, because he does not see me as his friend, but as a client. Sound familiar? That's what the contract is. This term, healthcare provider, is one that us in the ethics community are moving to dissolve. We are not healthcare providers. What that implies is that there's a dynamic of the physician-patient relationship, making it more transactional. We move from holistic care to service per payment. And we're set up for failure. If you're a provider, if a patient comes to you and asks you to do something for them and to do something to them, and it's not successful, you've provided what they've asked of you, they're not going to come back to you. They're going to think you failed. Whereas if you have, and we'll get into this, if you have a covenant with that relationship with them, which is a relationship based on mutual trust, respect, integrity, understanding of each other's shared values, there's more to the relationship than that of a contract. I think it's important, at least from my perspective, when we talk about the ethical physician, that we remember that the heart of medicine is a moral enterprise. It's a moral relationship with our patients. I believe that some even go so far as I put there, when you enter the room a patient is in, it's considered a sacred place. That you have to have that intent of being present when present, to be the ethical physician making the best decisions with your patient, for your patient, as you care about them and care for them. And this covenant relationship is really allocentric. It's centered on duty to others, and that's really it is. And that's really what it's all about. It's caring about and caring for that patient. And we can do that by looking at these aspects in this book that I wrote, Covenant Medicine, Being Present When Present. Look at what our actions are: listening, speaking, intentionality. What's our intentionality? What's our commitment? What do we willingly want to give up and give to our patients? How should we listen? Be present when present. Truth, grace, action, make best use of time, stay a while, ownership. And I'll give you some challenges here in a little bit to kind of implement some of these. And so in a covenant relationship, here's what we need to do. We need to ask, what is wrong with our patient? What can be done for our patient? Not necessarily to our patient, but that's important. Yeah, but what can be done for, and what should be done for our patient? So ask these questions as we are at the bedside. And so I'm rolling down to the end here, and I just kind of want to summarize some of the things that I brought forth. That the ethical physician, that we are a great army of quiet workers, many times quiet workers, when we're at the bedside, reflecting on who we are. Our medical students hear me say this often. At one of the white coat ceremonies where I was, here's what I'd like you to consider. I want you to put on your white coat with pride. You've earned it. I want you to wear it with humility. There's a big difference. You are not a god in a white coat. And I share with them some of my experiences, and I learned the hard by having my hands slapped on rounds by parents and by others and by nurses who took to task. And if that's the case, then we need to be there with them and for them. They don't have a choice but to trust us. And we need to remember that we impact people every day of our lives, whether we realize it or not. Sometimes we're ignorant of what we left behind, and that's with our patients, depending on how we act in front of them and with them, and the decisions we make with them and about who they are and their illness. Mr. Smith, tell me a little bit about who you are so that I can better understand why you're having some abdominal pain. It may be something that's going on in your life that we need to address. Yeah, it could certainly be an ulcer, and we'll take care of that. But let's talk about a little bit more about who you are. And as I tell our medical students, when you look in the mirror, I want you to see who you are. Everyone will see what you are. It'll be on your white coat, medical student, physician, MD, what have you. But when you look in the mirror, I want you to kind of see who you are. I want you to see who others are seeing who you are. So final thoughts. The ethical physician has to simultaneously make a technically and medically right decision and best decision that's morally good. But they may not be the same, and that's where you have to kind of engage in that conversation, moving forward from one to the other. Key point, every decision we make has a consequence, and we own that decision now and forever. And that's where you have to kind of really be a hard taskmaster on yourself and on ourselves as ethical physicians when we're at the bedside with our patients. And so when we talk about the patient's good, it really centers around this dignified human being, the person. And the question is never whether, but how we're going to make that medical decision because it relates to the human dignity of the patient. That's the ethical physician. So here's a challenge that I give my fellows. I gave my fellows, critical care fellows, my residents, my medical students, and even to our medical students who now are entering their clerkships. I want them to hold the hand of a patient who can't respond. And I want them to feel how vulnerable they are. They're just holding a hand. But to begin to understand that as an ethical physician, one with a medical humanistic approach, how humbling it is to know that all you can offer is comfort, but more importantly, what a privilege it is to do so. Because who else can do that? Who else is there? And that's part of being the ethical physician, being bold and courageous enough to be there and show compassion, empathy, doing what is best for your patient, and answering those 5 questions that I posed. To be with your patient always, be present when present. Think about that. What does that all mean? And the last thing I want to share with you from being an ethical physician is the most powerful tool that physicians bring to the bedside is themselves. No more, no less. And that's what the ethical physician is all about. And I leave it at that to answer any questions you have, comments, or anything you'd like to kind of talk about. But thank you again for this opportunity to share with you. And I trust that this gave you some insight to how I think about things as an ethicist and an intensivist at the bedside.
Thank you so much for the talk. Anybody have any questions that they'd like to ask? We've got another 10 minutes or so before we wrap up. I did have one question when you were talking about the stuff with your students and how surprised some of them get at times when they find that they're somebody they look at as a friend has a completely divergent opinion than they've got. How do you manage that process in maintaining professional discourse? And I'm specifically thinking in terms of in the current climate that we're in, the need or the want of students who are morally outraged that somebody's got a different opinion than theirs to somehow cancel their perspective.
So, good question. We are very open, and the students know this, that they are entitled to come together to have a conversation. That, to be honest, I don't actually allow them to leave unless there's an open conversation between the two, explaining the reasons why they may feel differently. And I know, and they've shared it with me, that after class, they will get together and they'll have conversations and they come together, they understand each other, but they also use something called Discord, which I'm sure you're familiar with, and Slack, and they have conversations there. Sometimes they'll actually come to my office, with the two factions, so to speak, and we kind of talk about it. So they know that this is an open forum, that I share with them. This is what you're going to feel like on rounds when you have 15 people on rounds and you're going to have a disconnect. And so let's talk now about how can we go about making that better for you. So number one, I never let them move on without having that conversation. And it's interesting because our students welcome that. They really welcome that. Right. And it's been pretty interesting that, they don't actually try to convince each other their position. But what I find is that by doing that, they begin to understand what respect really is.
So I have a question, David. I was a clerkship director for a few thousand years, and one of the characteristics that I think applies to all clerkship directors at all schools, certainly in North America, is they are intensely defensive of their time. My clerkship is only X, and it really needs to be 5 weeks longer. How well did they accept, and what sort of sales pitch did you need to use? And I'm going to use a slightly stigmatized word, but it's the only one I can think of. When you inserted ethics and humanism into the clerkship space, how did you say, no, this will work, and it'll be good for your clerkship, and it'll be, of course, good for the students? Well,
we were able to do this years ago when we started the curriculum by embracing the clerkship directors in a room and sharing with them the reasons why this was so important, and engage them in some of the things that they wanted to see related to their particular clerkship. For example, with neurology, the whole concept of personhood. I would ask them, the neurology clerkship director, how are you embracing the concept of personhood when you have a patient that comes in with a massive stroke and the patient's now simply going to be vegetative? What are you teaching your students related to that? Or are you just teaching them a stroke? So what we did is we brought them into the fold and made them owners of the ethics content within their clerkships. And it's worked out very, very well. The clerkship directors will actually, so I meet with the medical students during their clerkships, and we talk about the ethics related to a particular case that they bring up related to their clerkship that they're on. And the clerkship director, not often, but many times, are actually on those calls, are in that classroom, so that they hear exactly what the students are going. I can't tell you why it worked, other than we really invited them to be part of the development of the curriculum in terms of the 3rd and 4th year.
So I have a question. I was teaching a course called Reflective Practice. I have physicians in my course who take time to read the attending book by, I'm sorry, his name's escaping me right now. And then they also reflect on their approach to the teaching and learning that they do, and also the patient care that they do. And they read articles about narrative medicine and all of these things. And every time people talk about how impactful that course is and how it kind of shakes their mindset a bit. But, so there are little pockets of things going on. What larger movements do you see going on, or how can we start to get some momentum to change, and adopt this approach, this humanistic approach to medicine, this ethical approach? I know this event today, we have 9 people on the screen. So what's the bigger, where do we go big with this,
I wish I could tell you, other than the fact that my community of ethicists are really engaged in this. I can just share with you what we do. And for example, being invited to kind of talk about this in your forum is really one of the only ways to do this. So when you're talking about narrative medicine, that's a big part of our bioethics department. So we do a lot of journaling, narrative medicine, and actually I have an independent elective for our 4th year students that many of them take, called The Art of Storytelling, where I use a book. I use this book, the science of the. I don't know if you can see it. The science. It's called The Science of Storytelling, where our students will spend 4 weeks developing a story related to a patient. And so, I think I don't know how to answer that other than to make it just have forums like this. And it is frustrating. I don't know what else to tell you. I think it's very difficult to do. We just have to be conscious. And like I said, I appreciate the opportunity to kind of speak here at this forum. 9 people, 7 people, 5 people. It is what it is.
I have a question. I know we only have a few minutes. So David, I was really intrigued by what you said, the difference between contract and covenant. So I just was wondering about, how can an ethical physician survive and thrive in a healthcare system that is, for the most part, really very contractual?
Very difficult. I'll be real candid. I think it's very difficult to do. And that's where your ethics committee for that particular hospital has to play a significant role in changing the philosophy of moving from a contract to a covenant philosophy of the hospital. It's very difficult to do. And so I understand what you're saying, and I've been witness to it. And that's where you have to come into play. This is kind of where I alluded to the law and ethics are like oil and water. They don't mix. I can tell you that a contract and ethics, they don't mix well either. And so that's where you have to kind of be bold and courageous enough to move forward a little bit. But I understand your point, and I see it. It's hard to do. It's hard to do. I will be candid. I think the more secular a hospital is, the more contractual they are, and the more faith-based hospitals, the more covenant relationship they have, and their ethics committees are different. So within our town of Phoenix, we have our association with a secular hospital. The Banner system is very secular. Their ethics committee is very humanistically approached. Why? Because we've all worked together. We understand that. But we also have a faith-based hospital, St. Joseph's, et cetera, that's also that way. But it all depends on where they're coming from. So it is an issue. I will share with you that our students, I will be very candid with you as well. Our students, I'll also look at that as well. What their own secular, so yeah, here, yesterday they had a lecture on conscientious objection, the moral responsibility of physicians who have healthcare right of conscience. And I was talking about, and I give them a balanced approach. There are times when you may feel you have a moral conviction that you just can't do what the patient's asking of you. What do you do? Can you refer? And if you do, how complicit are you in that referral? How do you get around that? If you're strongly convicted because of the faith, what do you do in that situation? And a student raised their hand and said, well, what if I really don't care about faith? I'm an atheist. What do I do there? How does that work? So our students are actually thinking about that contract covenant relationship. I said, what do you think? What would you do? Well, I may be an atheist, I'm not faith-based, but I just don't believe in this particular procedure that they're asking of me. So I'm going to go ahead and refer and help them out a little bit. So these are concepts that we talk about in medical school. They're very difficult. But at least what we are doing is giving our students an opportunity to find their own meaning in the stuff we talk about, and find their own meaning in where their moral foundation is, and then move forward. I think you're muted, Gary.
I am muted. You'd think after all this time we wouldn't do that anymore, but we're actually over on our time.
Okay.
So I appreciate you taking the time to do this, and it's been a great session. And so truly appreciate it.
My thanks. Anytime. Let me know. Take care, everyone. Bye-bye.